Good morning, everyone. I would like to welcome everyone to the Health for the World COVID question and answer session with Dr. Grasselli. As you all already know, Health for the World is a nonprofit initiative which aims to promote health worldwide. We believe that every human should have access to basic health services worldwide. We have healthcare professionals from around the world today who have joined us for the session. We are united at this time to fight this pandemic. I'll start with the introductions. I am Dr. Bhavya Rehani. I'm the president and co-founder of Health for the World and faculty at UCSF. We have Dr. Bill Dillon here. Dr. Bill Dillon is the executive vice chair of radiology and at University of California, San Francisco, and co-founder of Health for the World. We have Dr. Ankur Parija, who's co-founder of Health for the World and director of inpatient geriatrics and palliative care at Stanford University. I would like to introduce our speaker today. Our speaker today is Dr. Grasselli. Dr. Grasselli is an associate professor of anesthesiology and intensive care at University of Milan. He's a medical director of intensive care unit at Ospedale Maggiore Policlinico in Milan. He's also the coordinator of COVID-19 ICU Network in Lombardy and has published multiple very good articles in JAMA and has been recently featured in NPR. The format today will be simple. Dr. Grasselli will be presenting his slides and a presentation. After that, we'll have a question and answer session. So please, you can type the question in the chat box in the Zoom at the bottom. I know many of you have already submitted the questions beforehand, which we will address towards the end of the session. Thank you so much, Dr. Grasselli, for doing this for us. We are honored to have you. So when you're ready, please start with your presentation.
Okay, thank you, and hello everyone. Thanks for the introduction, and thanks for this invitation. So I will briefly tell you what happened here in Lombardy. Lombardy is the region around Milan, basically. It's a very wealthy, very organized, very modern region with, I would say, quite a good healthcare system, but despite this, we've been invested by this coronavirus infection with extreme consequences, as I will show you. So my first slide is this. These are the epidemic curves for seasonal flu. And as you can see, you can see here what happened in Lombardy. You see that the curve, the black one, not the dotted one, the black one got to a peak and then went down, but didn't decrease as usual. But at a certain point, it remained high. And these are probably cases of upper respiratory tract infection or pneumonia that were misdiagnosed as influenza, but that were probably due to coronavirus. So this slide tells us that probably coronavirus infection was around for a few weeks before the first case was diagnosed, and it was misdiagnosed as flu. And indeed, our general practitioner are telling us that there was in the end of January, beginning of February, and a strange number of atypical pneumonia in our territory. So this tells us that the virus had time to infect a lot of people before the first case was discovered. So the first patient was diagnosed on February 20. And you can see here, then, as you know, 3 weeks after, the WHO declared the coronavirus infection as a pandemic. And now Italy is one of the most affected countries in the world. We still don't know many things about this infection. Basically all what we know comes from the experience in China, but as you know, both the population and the healthcare system there is quite different from that the one we have here in Italy and in the Western world in January, in general. So, for example, the proportion of hospitalized patients and the proportion of patients needing ICU is different, for example, in our population compared to the Chinese data. And we strongly believe that knowledge of the baseline characteristics and of the outcomes of those patients is extremely important, not only from a scientific point of view, but also for the preparedness of the health system to the outbreak. So this is what is happening in Italy. In Italy, we have now these slides are taken from a few days ago. We have now something like 120,000 cases of COVID-19 and a high proportion of healthcare workers infected, and a certain number of deaths. And you can see here on the right-hand side, you can see the curve and the distribution of cases in our country. This is the map of the country in mid-March, and this is how it is now. So you can see that the disease has spread all over the country, even though the epicenter remains in Lombardy. And on the right-hand side, you can see the age distribution and the case fatality rate. And the median age of our cases in Italy is around 63 years old. And you can see here that the case fatality rate increases sharply with age. This is a very important point because, as you know, a lot of people is saying that we have high mortality here in Italy, which is true, but this issue has been very well described in this paper published by Dr. Onder and Dr. Brusaferro from our National Institute of Health, Istituto Superiore di Sanità, and just published in JAMA. And they demonstrated that the case fatality rate is basically the same as reported in China up to the age of 69. And then it increases sharply after the age of 70. Clearly, the Italian population has a significantly older age compared to China. So we have more patients in the classes of age above 70 years old, and that's the first point explaining the high mortality in our country. The second point, and probably the most important point, is the denominator problem, meaning that at least in Lombardy, we are now testing only severely symptomatic patients. So we basically select from the beginning the patients, and we are not testing asymptomatic or partially symptomatic patients due to the incredible number of patients we have and due to the shortage of diagnostic tests that we had, especially at the beginning of the epidemic. So clearly, the number of patients who die, the percentage of mortality is calculated on a smaller denominator compared to other regions in Italy or other countries in Europe who are testing aggressively also asymptomatic patients. And this is quite important, and we are now that we got to a peak of the infection, the number of cases is starting to slightly decrease. We are now moving to a more aggressive, to a phase characterized by a more aggressive strategy of contact tracing and of testing also asymptomatic patients in order to identify asymptomatic individuals and to isolate them. But until now, we haven't been able to do that. And this is the reason why our mortality expressed as percentage of the total of positive cases is quite high. But again, we are testing only symptomatic patients. You have to think that, for example, in Lombardy, now almost 50% of the swabs test positive, while we estimate that something like 10 to 20% of the population should be infected sooner or later. And the third point to explain mortality is the definition of COVID-19 related deaths, meaning that now almost every case of death is caused by coronavirus, or at least is ascribed to coronavirus, but this is clearly not the case. We're having deaths of patients who are dying for other causes, like, for example, myocardial infarction or stroke, who are not related to coronavirus, but since they come from endemic zones, they take a swab, may even post-mortem, and the swab tests positive, and so those deaths are ascribed to coronavirus. So there's a distinction between patients who die for coronavirus or who die with the coronavirus. Anyway, this is only speculations. The truth is that we have something like 120,000 people infected in Italy, and more than 10,000 deaths, so which are very big numbers. Again, in Lombardy, this is what happened in our region. On February 20, a previously healthy 38-year-old man with atypical pneumonia was diagnosed with coronavirus in a small hospital in Codogno, which is a little town just south of Milan. The story is quite funny because this patient went twice to the hospital, and they were not able to diagnose the cause of his pneumonia until an anesthesiologist of the hospital decided to test him against the advice of the infectious disease consultant, because this patient had basically no epidemiological criteria. The only clue was that he had dinner 3 weeks before with people coming back from China. But those people in the end tested negative. So this was the first problem. This guy is our patient 1, but we haven't been able to identify a patient 0. And the other thing that was quite scary was that the day after the first patient was diagnosed, we had 36 new cases without links to patient 1. So this again was quite scary for us, because we immediately realized that many positive patients were probably around, and that the virus had the time to infect a lot of people. We also knew from Chinese data that this disease usually does not affect very young people. And so again, the fact that our patient 1 was quite young was quite worrying. And so after February 21st, after the first 37 new cases, we immediately established an emergency task force in the government of the region where I am in this moment. And we tried to understand how to respond to the COVID-19 outbreak. So the total ICU bed capacity in our region before February 20 was 750 beds, which is slightly less than 3% of the total hospital beds. And so that was our previous ICU bed capacity. And so our idea was to create a network of COVID-19 cohorts, of COVID-19 dedicated ICUs at the beginning in 15 hub hospitals that were selected because they had an infectious disease department. So what we did was, since we do not have enough beds with single boxes and negative pressure rooms, we decided to cohort the patients in dedicated ICUs. So for example, in my hospital, we converted the neurosurgical ICU into a COVID-19 ICU with different pathways for infected and non-infected, and with a certain number of air changes. And this cohorted ICU is completely separate from the rest of the hospital and from the rest of the other ICU beds. So on February 24, like 3 days after the first diagnosis, we basically had a network of 15 COVID-19 ICUs in 15 hospitals, and we had a central coordination here at in the government of the region in order to allocate every COVID-19 patient who was intubated into one of these cohorts of these dedicated ICUs. Then the number of patients increased so much and so quickly that in the end we had to involve almost all the hospital of the regions. And now we have 1,750 ICU beds in the region. Of these, 1,500 are occupied by COVID-19 positive patients and 250 for COVID-19 negative patients. So we have been able to increase to more than double our total ICU bed capacity in less than 6 weeks. And to achieve this goal, I think that the role of central coordination was very important. This coordination was done by myself at the beginning, and then I have now people who is helping me. So basically, whenever a COVID-19 patient is intubated, the hospital calls us, and we try to allocate that patient where there is a free bed, of course, and until this was possible, also in different ICUs according to the characteristics of these ICUs. So, for example, the experience in treating ARDS, ECMO capability, and so on. Another very important, so now again we have this network of COVID-19 ICUs that are now 72 in about 50 hospitals in the region. And again, we increased our ICU bed capacity from 750 to 1,750 ICU beds. Clearly, we stopped every elective procedure, especially elective surgery. And so we have been able to staff these new ICU beds with anesthesiologists and with anesthesia nurses. Clearly, the doctor to patient, the nurse to patient ratio is less favorable than in usual condition. That this is clear. Another very important decision that was made by the government of the region was to reorganize the entire hospital network of the region. In particular, they decided that they wanted to centralize the time-dependent diseases like myocardial infarction, stroke, trauma, in a very limited number of hub hospitals within the regions. So, for example, now, severe trauma is centralized only to 3 hospitals in the region. Lombardy has something like 10 million people living here. And so there are 3, for example, 3 hubs for trauma and emergency neurosurgery, which are, it's one in Milan, one in Brescia, and another one in Pavia. So doing so, they've been able to reconvert, for example, the neurosurgical ICUs into COVID-19 ICUs. So we have been able to increase so much our capacity by creating new ICU beds, by stopping elective procedures, and by reorganizing the hospital network. And then the most important point has been that we put in place very strict containment measures. And as you know, now Italy is basically locked down. Then Italians are not very keen to following the rules, but I have to say that most people are now actually following the rule of staying at home and of leaving home only for very, very important reasons, like, buying food or going to the pharmacy and nothing more. And this has been extremely important to reduce the speed of the increase in the number of patients. This is how our total ICU bed capacity and the number of patients admitted to ICU increased over time. We have now almost 1,500 patients currently admitted to one of our ICUs. And in these 7 weeks, we have treated a total number of 3,337 patients. So more than 3,000 ICU patients in 7 weeks. So it's an incredible number. If one would have told me 2 months ago, you will, in Lombardy, you will have 1,500 ICU beds dedicated to COVID-19 patients, and you will treat more than 3,000 patients in 7 weeks, I would have said, well, it's impossible. But actually, basically, it happened. Of these 3,000 patients, almost 800 have been discharged, almost 1,000 have died, and again, we have currently in ICU almost 1,500 patients. A very important point is that more than 90% of these 1,500 and of these 3,000 patients are intubated and under invasive mechanical ventilation. So they are really level 3 ICUs. Because what's happening here is that we have these 1,500 patients in the ICU, and we have now almost 3,000 patients with CPAP in the wards. So we have an incredible number of patients receiving a non-invasive ventilatory respiratory assist. And in Italy, the most common assistance is CPAP, helmet CPAP in particular. So basically, and all those patients with CPAP in the wards are visited by an intensivist at least once a day. So we say that our ICU bed capacity is increased to 1,800 beds, but these are only level 3 beds. And then we have an incredible number of level 2 beds in the wards that we are still working on. So basically, what we learned from our experience during this COVID-19 outbreak is that the outbreak is characterized by an important mismatch between the number of patients requiring intensive care and the number of available ICU beds. So whenever you are waiting for an outbreak of COVID-19, you should try to understand how you can increase your ICU bed capacity, and maybe you could think of reproducing our system of a network of dedicated ICUs to optimize patient allocation and isolation in the hospital. An extremely important point, is the protection of healthcare workers. So now the availability of personal protective equipment is limited worldwide, but we have to make every effort to have enough PPEs and to train healthcare workers on the proper use of PPEs. And what helped us a lot was also to define and to establish protocols for the triage and for the treatment of COVID-19 patients. And I can tell you that our standard of treatment has changed during these 7 weeks. So this was what I wanted to tell you about the organization of our network. And now in 10 minutes, I want to show you some data about the clinical characteristics of our patients This is a huge work which should be published today in another major journal. The only couple of words about the clinical presentation of COVID-19. You all know this, so I'll go through this very quickly. You know that the most common symptoms are fever and cough and fatigue. There are also less common and rare presentations, and there are also individuals who are symptomatic carriers, but who can transmit the disease, as we all know. The severity of the disease can be classified according to Chinese CDC in mild, severe, and critical disease, where mild disease are patients without pneumonia. Severe disease are patients with pneumonia characterized by dyspnea, tachypnea, blood oxygen desaturation, and lung infiltrates at the chest X-ray. And critical disease, which should be around 5% of all cases, is characterized by respiratory failure, ARDS, septic shock, and multiple organ failure. And here on the right-hand side, you can see the distribution of the severity of the cases in Italy, where you can see that a good proportion are without symptoms or with very mild symptoms, and a certain proportion, something like 20% of the cases, are severe or critical. And this is what is happening now in Italy. We know that the disease has a typical radiological presentation, both at the chest X-ray and at the CT scan. And in some countries, the CT scan has basically replaced the swab for the diagnosis of COVID-19. So it's quite typical. These are our data. We collected the data from our ICU network that I described you before. We collected all the data from the patients tested positive for COVID-19 infection, admitted to our ICUs in Lombardy from the start of the epidemic to March 18. We recorded data on an electronic worksheet during the daily telephone calls that people from the coordinating center were doing to every COVID-19 ICU in Lombardy. And we recorded these simple data like age, sex, and comorbidities, mode of respiratory support, level of PEEP, FiO2, PO2, and MPF ratio, use of ECMO and prone positioning, and we have an outcome. And for this work, the outcome has a very short follow-up, but I can tell you something about longer-term outcomes. In our patient population, we analyzed almost 1,600 patients, and that's the reason why this paper has been accepted in, again, a major journal. 1,600 critically ill patients admitted to ICU. First thing very interesting is that 80% of our patients are male, and only 18% are female. Here you can see the age distribution. Only 4 patients of less than 20 years of age, 56 between 20 and 40, and a big number of patients between 40 and 80 years old of age. With regards to comorbidities, 70% of our patients had at least one comorbidity, and clearly comorbidities were more common in older patients. Half of the population was hypertensive, had hypertension, and we are now analyzing the type of antihypertensive drugs, but have no data on this today. And the second most common comorbidities were cardiovascular disease and dyslipidemia, while only a very small proportion of patients had a previous history of lung disease. All our patients needed some form of respiratory support, and something like 90% required invasive mechanical ventilation, and only 11% of the patients admitted to ICU required non-invasive ventilation. As I was telling you, the vast majority of patients treated non-invasively have been assisted in the wards, especially with the helmet CPAP. At admission, almost 30% of the patient had been proned, and there are missing data on this. And so I expect that this percentage is, in real world, is probably higher. And only a very small number of patients have been treated with ECMO. Then if you want, we can discuss this, but this is our data. From the respiratory mechanics point of view, what I can tell you is that we also have additional data, and the majority of patients are characterized by a high compliance of the respiratory system. So if the tidal volume is kept at 6 ml per kilo of ideal body weight, most of the patients have low plateau pressure and low driving pressure, but they all have a high mean ventilation, high ventilatory requirement, because they have high dead space fraction. So these are the values of PEEP, FiO2, and PF ratio. So the median value of PEEP is 14 centimeters of water. So I would say a reasonably high level of PEEP. The median FiO2 is 60 to 70%, and the FiO2 on the first day was higher in older patients. And the median PF ratio was 160, but we had a certain number of patients below 150 and below 100. And the PF ratio was higher in younger patients. So this is the outcome at only 8 days of follow-up, because the outcome was taken on March 22nd. And you can see that 26% of those patients had died in the ICU, 16% had been discharged alive from ICU, and 60% of the patients were still in the ICU, because the length of stay in the ICU is quite long, is 9 days for patients who die, but something like 16 days for the patients who remain on mechanical ventilation for longer. And if you look here, the death rate in the ICU, according to the age classes, you can see again that the death rate increases linearly and becomes very high after the age of 70. That's only a curiosity. Patients with hypertension, who I remind you are half of our patients, were significantly older, had higher PEEP levels, had lower PF ratio, and died more. So the incidence of hypertension was higher in patients died in the ICU compared to those discharged from the ICU. But again, the follow-up period is very short. So this study has, this data has certain limitations inherent with the retrospective nature of the study. Again, there are some missing data because, as you can imagine, it's difficult to collect data from 1,500 patients every day. And not all the centers had the time to transfer all the data every day. And again, the follow-up is very short compared to the course of the disease. And so what are the main messages from this case series is that the majority of our patients were males. Half of them had hypertension. A large proportion of them required invasive mechanical ventilation and relatively high levels of PEEP, and ICU mortality, but again with a very short follow-up, was 26%. And then if you want, I can tell you that we have now data on longer follow-up and even some preliminary data on 28 days mortality. So this was my last slide, and I'll be happy to take your questions. Thank you.
Thank you so much, Dr. Grasselli. This was an excellent presentation, and I think you covered a lot of good information, which I'm sure will help physicians around the world as we prepare for COVID. We have a few questions which the audience has submitted beforehand, and we're just going to ask them. Bill, do you want to ask the question which was submitted, one of the questions?
Yes. So first of all, thank you, Dr. Grasselli. That was so very interesting and a lesson to us all to get prepared. There's several questions about the treatment, in particular about antivirals and antibacterials, antimalarial drugs. I wonder if you could comment on whether any of your patients received those, and if so, was there any data from those that we could use?
So, first thing I can tell you is that the pharmacological treatment of the disease has changed over time. Second very important point is that basically there are no firm evidence from the literature about any of the treatment that we are now using. So what I can see is that there are centers who, try to strictly follow the evidence, and so they basically don't do anything. So they don't do antivirals, they don't do steroids, they don't do chloroquine. While there are other centers who are trying to give to every patient every treatment. And since there is this very high number of patients, and every day you have to try to find new beds for new patients, it's very difficult to do research following the classical conventional rules. So this is a population that would be ideal for randomized trials, because you have an incredible number of patients, very similar to each other. So it would be very easy to do randomized studies. The problem is that if you have so many patients, it's difficult to do classical research, but we're still trying to do some. Anyway, about antivirals, we started giving to anyone lopinavir and ritonavir. But then after the publication of the paper in the New England Journal of Medicine, though there are limitations on that study, some centers abandoned the use of antivirals, especially after the first days of the disease, when you know that the viral shedding is higher. Second very debated point is immunomodulant drugs and steroids. What we are now doing is that what we see is that some of these patients have a huge inflammatory flare and very high levels of cytokines, IL-1, IL-6. So what in many centers they are trying to give steroids and anti-IL-1 or anti-IL-6 in the first phases of the disease. So now we are now admitting patients in the ICU who are already receiving steroids and anti-IL-1 or anti-IL-6, which are now becoming very popular. But at least for those treatments now, the Italian FDA is mandating a couple of randomized studies. Third point is anticoagulation. We are seeing a very high incidence of deep venous thrombosis, a pulmonary embolism, and thrombotic events. So now we are starting to anticoagulate every patient with an elevated D-dimer level. So these are the three, I would say, most important changes that we made in our pharmacological treatment of the disease, and we are not administering prophylactic antibiotics. So we are administering antibacterial drugs only if we have a documented secondary bacterial infection.
Very good, thank you. And about chloroquine, you know, this is very controversial in our country right now because our president seems to be going out and saying that we should use this or people should use this, and others, of course, there's no randomized controlled data. Have you any experience with that?
There are no trials, there's no evidence. Again, the Italian Society of Infectious Disease recommends chloroquine. So we are still giving chloroquine to patients. We're not using it as a prophylaxis because there are countries who recommend chloroquine in prophylaxis, but that I think it's clearly without any rationale. So we're using chloroquine in every patient because basically they are treated with chloroquine as soon as they have the diagnosis. And so we receive them in the ICU with chloroquine treatment ongoing. And we are not stopping it unless we see serious adverse events. But I'm gut feeling I'm not, how can I say, I'm not convinced that it changes the history of the disease.
I guess I had a follow-up question there, Dr. Grasselli. Is there any data from Italy that is available for remdesivir trials from the trials?
What is there any data?
Any data that has come out of the remdesivir, the drug?
Remdesivir, no. We're using it as for compassionate use. So we are asking our ethics committee the permission to use it in most of the patients. I don't personally, but again, it's a gut feeling. So I'm not being scientific in this. What my colleagues tell me is that the mortality of these patients in our center, for example, is decreasing over time. Things who are probably contributing to this decreasing mortality are that we are trying, now that the pressure to find a free ICU bed is slightly decreased, we are now trying to admit patients who failed non-invasive ventilation earlier. So we try not to keep the patients on CPAP for days until they fail, which is always a very good rule. The point is that you need to have a free bed and a free ventilator to do that. Second point is that steroids and anti-cytokines treatment, at least for some patients, seem to be beneficial, but again, it's a gut feeling. And also anticoagulation seems to be beneficial because we lost some patients for pulmonary embolism and thrombotic events. For example, in my whole life, I haven't seen I saw a couple of patients who died during the pronation maneuver. And this never happened in my ICU. I mean, my ICU is the ICU that was directed by Luciano Gattinoni. And the prone supine 1 and 2 studies were done in that ICU. So we have a lot of experience in pronation. I have to say that we prone every ARDS patient with PF ratio below 150. And we prone them while they are on ECMO. We prone very severely obese patients. We prone them when they are track customized. So we have no problems in proning any patient. But this is the first time I see a couple of serious complications during prone positioning. cardiac arrest due to pulmonary embolism. And we conducted just, again, I'm telling you our experience, it's not published yet, but we did a sort of screening for deep venous thrombosis in the respiratory disease department, and we found something like 23% of the patients had the deep venous thrombosis of the legs. And the only disease...
23% in the ICU, 23% in your ICU patients?
23% in the patients admitted to the pulmonology department, not even in the ICU. So we're now doing, a study in the ICU also and in the hospital, but the incidence seems quite high. So what we recommend now is to test the D-dimer. It's known from the literature that patients with high levels of D-dimer have a worse prognosis, and to test the D-dimer, to consider anticoagulation if the D-dimer level is high, and to maintain a very high level of suspicion for deep venous thrombosis in any patient with elevated D-dimer levels. So this is what we do.
Dr. Grasselli, there's a question about healthcare worker safety. As physicians and nurses, people worry about their own safety. I know you mentioned about PPE and proper training of the PPE for the healthcare workers. The question we have is, how do the healthcare workers make sure that they do not infect their families, their children, and their wives? And did you do anything extra to ensure the healthcare worker safety during this time?
Well, first of all, unfortunately, it's impossible to make sure. So the most important thing is to use properly the PPEs and to follow the recommendation of the World Health Organization. So we use in the COVID-19 ICUs, we use N95 or FFP2 masks. We use impermeable gowns, a double pair of gloves, and the glass cover. So, I mean, what's recommended by the WHO? Indeed, I think that if you wear the PPEs, it's not so easy to be infected in the COVID-19 ICU. Also, the exhaled air from the ventilator is filtered by an antiviral filter. So probably healthcare workers get the infection when they meet for outside the COVID-19 ICU, when they, during the handovers, for example. Those who can, they try to stay away from their families. For example, I'm not seeing my kids. I haven't seen my kids in the last 2 months. Not for the kids, but for the grandparents who take care of the kids. Mm-hmm. And but I know that this is not feasible for everyone. What we are now doing is in some regions, in some Italian regions, they test healthcare workers like every 5 to 7 days with a swab.
Right.
This is not feasible here in Lombardy. In Lombardy, we have something like 400,000 healthcare workers.
Right.
So we know we do now something like 10,000 swabs every day, but they are now starting to do a rapid serological testing of all healthcare workers. So not with the ELISA method, but with a very simple, blood droplet method, like pregnancy test. So, which clearly has not a perfect sensitivity and specificity, but at least can help identifying those people who have been in contact with the virus, and maybe to select those who are candidates to the swab. And then once you identify the carrier, you should try to isolate him, if it's possible at home or in a specific environment like, I don't know, hotels or facilities where they can be isolated from the families, because what we are seeing now is a lot of familiar clusters of infection.
Mm-hmm.
Because in-house it's very difficult to do a proper self-isolation, especially if you have kids.
Right. And Dr. Grasselli, being a radiologist, I think there's another question in the chat box about the role of chest CT. I know you showed the chest X-ray and the chest CT. Did you use it routinely for the COVID patients, or did you have some guidelines about when to use chest CT and when not to use chest CT?
No, it's different from center to center. We go from one extreme to another. Some centers don't do any CT scan unless needed for serious clinical reasons, because moving those patients is a problem.
Right.
Other centers, they use CT scan instead of the swab.
Mm-hmm.
So there are centers where a patient with respiratory symptoms undergoes CT scan in the emergency department, and only if the CT scan shows an interstitial pneumonia, then they undergo the swab. So it's completely different. CT scan is a very important. It's a very important exam, not only for the diagnosis, but only, for example, for the quantification of the potential for lung recruitment, for selection of PEEP level, for example, of the respiratory support that patients need. But again, there are logistical problems. One curiosity that I can tell you is that we are now reviewing this chest CT scan that had been done in January and February in some hospitals of our region, and we have identified a certain number of CT scans that are highly suggestive of COVID-19 well before the disease was diagnosed. So again, this is another indirect proof that the disease was around at least 1 month before we diagnosed the first case, and we are now trying to recall those patients and to test them with antibodies to confirm that they had COVID-19 in January or early February, so well before the first case was diagnosed. So CT scan is a very important, very informative exam.
Right. Dr. Bharija had a question about.
Thanks, Dr. Grasselli. I know we're coming up into the hour, and there's lots of questions. One thing that jumping out of the numbers from Italy was, as you said, the case fatality rates above 70. It's clearly is different odds, when you're below 70 or above 70, and obviously it gets worse 80 and above as well. And what is your recommendation as we're sort of looking at forward triage or advanced care planning upstream for communities which are still maybe pre-surge, trying to prepare the older adults in the community and their families?
What I think is that this is not a common, usual viral pneumonia. So I'm pretty sure that we did not intubate and admit to ICU some patients that if they had a diagnosis of simple viral or bacterial pneumonia would have been intubated. But this was not only or not for shortage of beds, but what we are realizing now is that if you are 70, 72, 73, maybe you have a couple of comorbidities like diabetes and hypertension, and you fail non-invasive treatment, and maybe you also fail antivirals and you fail steroids, then if you are admitted to the ICU, you have a very, very high chance of dying. You have to stay on the ventilator for a very long period of time. You have basically zero chances of returning to an acceptable quality of life. It resembles more you know, again, this is a gut feeling, but it resembles more an autoimmune disease. You know, it's like that. Some of those patients, it's like the viral infection triggers a dysregulated, or whatever you want to call it, immune response. And if I tell you, if you have a 72-year-old man with an interstitial pneumonia with autoimmune features, or with an autoimmune disease who is not responding to steroids and is not responding to non-invasive ventilation or CPAP and needs a tube, would you admit him to the ICU? You would probably say no. It's not so different in this case. So it's not a flu pneumonia, you know. It's a very difficult disease to manage, and it's not managed as you usually manage infectious diseases. Mm-hmm. So it looks like more a systemic disimmune disease, certainly triggered by a virus. But there are patients who, I can tell you that there are patients who, after a while, they become negative. You cannot even find the virus in their pharynx anymore. Mm. But still, there is this huge inflammatory reaction that ultimately leads to multiple organ failure, which is probably related to the previous infection, but is then self-maintained by the immune system response. So that's I would look at this disease more as to a systemic disease, and if you know you have a systemic disease which is not responding to steroids and is not responding to and is failing CPAP after 2-3 days, then you really have to wonder if intubating the patient and giving him intensive treatments is useful or not. In some cases, some people advocate a sort of ICU trial. Like if you are in doubt, you intubate the patient, you admit him to the ICU. If the patient doesn't improve within a certain period of time, okay, you can stop the invasive treatment. It's very rational. The point is that we don't know what is a reasonable period of time, certainly not 3-4 days, because there are patients who stay on the ventilator with high PEEP and high FiO2 for 2 weeks, and then all of a sudden they improve. There are patients who seem to do very well in the first days, and then all of a sudden they die. So we still don't know a lot about this disease. The point is that we have not enough time to study it, because you know when you are invested by this number of patients, your first thought is that, okay, I have to find I have to give to the highest number possible of patients the minimum set of care, which is a tube, a ventilator, and some protective ventilation strategy, and some basic life support. So it's a very unique situation, I think.
Dr. Grasselli, I know that we're getting close to the end of our time with you, and we really appreciate everything that you've told us today. That's very sobering, very interesting. Maybe you could end with just what advice would you give to those of us listening now who have, around the world, who have yet to experience this tragedy, and maybe discuss a bit about the social toll beyond the medical aspects. I'm Italians, it's one of my favorite countries to visit. We love your country, and in part because there's so many great family and friend orientation. What's the social toll been, and how have the people
well, it's very high. It's we're going to pay a very high price in terms of not only of deaths, but also in terms of clearly economy, and as you were saying, social aspects, because you know, also this social distancing, isolation, it's very difficult to cope with. Healthcare workers have an incredible level of stress. It's a very, very bad experience, not only from a medical point of view, but also from a psychological point of view.
Yeah.
You know, you work, it's very, you have to work more than usual, more work shifts. Working with the PPEs is very uncomfortable, and you always have in the back of your mind the idea that okay, I might get this infection, and I may infect my family.
Yeah.
My family. So it's very bad. I would say that probably trying to set up a sort of psychological support also for workers, for healthcare workers, would be very important. Another terrible aspect of this is that relatives cannot visit, you know, the patients. So you don't see the relatives, you don't see the families. You sometimes have to discuss end of life issues, or have to tell them that the patient has died, and they on the phone. So
it's terrible. Yeah,
it's terrible. Yes, it's. I'm pretty sure that the world, the society, in some way, and hospitals for sure, will change after this.
Yeah. Well, we will all change, no question.
Yeah.
Yeah. And society will change. Fabio?
Closing remarks.
Yeah, thank you so much, Dr. Grasselli. We really appreciate you doing it for us. This was an excellent talk, which was very informative. Just the kind of information which our, you know, global community of physicians is looking for. So we really appreciate this. And thank you so much for answering the questions so well. There are a few more questions. I will just send you them by email because there were multiple physicians from around the world who have joined and who had some questions. I'm going to send you them by email. But thank you so much. Please stay safe and well. And thank you for the excellent work which you are doing in Italy, and also publishing it so that the world can know about how you are dealing with this crisis. Thank you so much.
Okay, thank you.
Thank you.
Thank you everyone for joining today, and have a great day. Thanks everyone.
Thank you.
Thanks.
Thank you.
Bye-bye.
Bye.
Bye-bye.
Thank you for all the work. Thank you for sharing everything. Take care.